All right. Hello, everybody. Good morning and good afternoon or good evening to Dr. Westman. My name's Penny Figtree. I'm a GP in Port Macquarie, and I'm probably the biggest Dr. Westman fan in the world because it's Dr. Westman's white coat video that you've got to Google after this talk if you haven't watched it, that completely changed my life as a GP. The reason being that Dr. Westman manages to make low carb really, really simple. And so, any nutritionist who wants to learn about low carb or any doctor or GP, honestly, you just have to follow Dr. Westman, watch his white coat video, and do everything that he says, and you'll be able to do it because it's easy. So, who is Dr. Westman? Well, he's an associate professor at Duke University. He's a researcher of 20 years. He's an obesity medicine and internal medicine doctor in Duke in America. He's published books with Jeff Volek and Steve Phinney. And he's also someone who actually knew Atkins, who went to Robert Atkins and said, how come your patients are getting well? We need to do research into this. And so Dr. Atkins actually funded some of Dr. Westman's original research. So he is a pioneer. And if you want to know about low carb, apart from watching his video, buy his book, End Your Carb Confusion. Get your highlighter out, memorize it, and just do that in all your patients, and you've got it covered. So often when I look on the internet and people are all worried about low carb, I think, but it's so obvious. Dr. Westman's already solved all these problems. So he's the man. Good luck, everybody, and enjoy this talk because it's going to be great. Welcome, Dr. Westman.
Thank you. Thank you for the kind introduction. I feel like I'm just passing along a baton in a race. I didn't create what I'm going to talk about, and give credit to those who did, hopefully. But like you, I'm trying to find out how to help my patients. So I'm an internist first, and I started, I guess, unlike many internists, I was a history major first, and I did my overseas, we call it overseas college in France, which looking back maybe made me a little more open to the idea of having, pate and fat and all sorts of foods that were not thought to be healthy. But anyway, the background. Oh, let's see. Try to get this slide. Oh, there we go. So I ended up at Duke University in Durham, North Carolina, after doing a very clinical residency at the University of Kentucky in Lexington. And the interesting thing is, looking back, is they kind of shooed me along. Don't you want to get more research training, was what I was told. And I was like, well, yeah, I do. Well, looking back, I was asking too many questions. And they wanted to push me down the street to a university, Duke University, which is known for its research. And so I did clinical research training early on as a physician and actually learned how to do clinical trials and how to assess the statistics of what you're seeing, And in the clinic, it's not easy. Often you see only the people who come back. And that's what I was faced with when I was curious about how to follow up on a clinical signal. Anyway, here are my conflicts, and I'm really not going to talk about any of these. So in 1998, two of my patients, I was a GP equivalent in ambulatory care or internal medicine at a Veterans Affairs hospital. That's the VA system all over the US. Two of my patients lost over 50 pounds. They were doing great. And I asked them what they did. And one of them looked at me and said, all I did is eat steak and eggs. And oh my goodness, what the? And he had lost all this weight, was healthy. By the time the second patient came, I kind of talked around a little bit and I said, well, your cholesterol probably went up and I don't want you to do that diet. And the patient said to me, why don't you check my cholesterol? And I did. And in actually these two cases, the cholesterol got better, however you looked at it, however you sliced it. And so I thought, well, where am I going to get research money? So I went to visit Dr. Atkins in New York City. He had a 4-story flat. He was at the end of a 30-year career. And when I said you need to do research, he said, but so I did, I'm the son of a doctor. My father passed away, but I knew that doctors could learn over a career. And so I thought I did what any person curious would do is I went to visit doctors who were using the diet that my patients used. And I sat in the office of Dr. Atkins. He said, why would I want to do research? I've been doing it 30 years. And I said, well, no one else believes you. And he knew enough to know that he wasn't regarded highly. And the idea that eating fat was bad was so strong at the time that our paper that came out in 2002, funded by Dr. Atkins, it's actually the same month the other kind of pioneering is called now. For us, it was just collecting data. Jeff Volek's paper came out at the same month as ours in 2002. And when we got into it, and Jeff said this just 2 years ago now, he said there's never been a study that showed a low-carb, high-fat diet, Atkins-type diet is bad. There's never been a clinical study that showed nutritional ketosis is bad. And actually, when we did our due diligence in 2000, actually, I think our paper was 1998, where we collaborated once and we looked in the literature. And best we could tell, there was one paper in 1980 that it was 24 people, and they kind of rustled up people at the NIH to do it. And they were put on the Atkins diet, and they all lost weight, but their LDL went up. And that was the final nail in the coffin of the Atkins diet. This is not science based on modern methodology. Well, even back then, it's not solid science saying it. No one died, So anyway, the prominence of the dominance of the fear of eating fat and the fear of the LDL cholesterol going up, it was so strong that there was a taboo from 1980 to 2002 when our papers came out. Now, that doesn't mean people started following it. The diet papers came out over, 2002, 2003, 4, 5. Now there are meta-analyses of those papers of low carb versus low fat, which, I hope you have no worry about safety and efficacy, especially compared to low-fat diets. It's stronger in terms of obesity treatment. And so today, in the book called Ketogenic, The Science of Therapeutic Carbohydrate Restriction, this is a must purchase if you want to get even I use it with my patients in the office, kind of as a show and tell. I show the Banting diet book from 1850 for obesity treatment. I show the Osler textbook of medicine from 1923, come with this tattered piece of paper and say, this is what doctors used 100 years ago to treat diabetes. And so by any of these names, it's now the science has come back to say, okay, this is fine to do, at least for a therapeutic tool. And I think that's the consensus of the mainstream, even obesity experts who might not think it's their favorite thing. But now what's controversial is whether, when you reverse all these diabetes, obesity, hypertension, basically any internal medicine problem I am trained to use drugs for, I can reverse using diet. But the controversy is, what do you do then when it's all fixed? And I'm pretty confident and comfortable with people continuing on a keto diet. In fact, it's what got them here. So it's kind of nonsensical to think that, well, you can use it as a therapeutic tool, but once they get to their healthy goal, get them off it. And it's like, well, wait a minute. So actually, it was diet doctor Andreas Ienfeld who had a meeting. We were looking at a poster, and he looks down at the poor investigator, and he says, well, at 1 year, what did you find? Well, at 1 year we can't go beyond. He said, no. He said, what, did it look okay and look good at a year? And she said, Yeah, it looked fine. But so no one says, well, they're just assuming that at a year and a day, the ship might go off the edge of the world. So anyway, it's been interesting to see this, and what I want to do is just dispel those old fears, because we lived through them. Although the younger researchers, especially, are not so beholden to that kind of shackles, if you will. So I'm going to switch. This is kind of what I use in my clinic now as a teaching method. It's kind of like we have ingredients for a meatloaf, and then we put it in the oven to bake it. So the idea that we're made of humans are made of ingredients, and we need energy to function, to supply the enzymes and heat, and keep the lights on, so to speak. So they're ingredients for a meatloaf. They're actually ingredients for a human. The prep time on average, it's said, is 8 minutes. Now that's supposed to be kind of funny. It doesn't always translate societally but anyway. Incubation time, 9 months for a human. Cook time, 18, by the time that you kick them out of the house after their teenage years. So the ingredients basically are water, protein, and fat. So if you were going to make a human, here are the ingredients, but you have to fuel the darn thing. But you can fuel the human on carbohydrates, the sugars and starches, or on fats. So I teach now separating what the diet is for metabolically, and that's to create and replenish the body composition. That's the water, the protein, and then to fuel the body, and that's the carbohydrates and the fats. And so even before I start talking about what diet to do, I try to just establish the playing field. But most people are just unaware of what the body is made of. Medical students who rotate through, I'm at a university, residents, medical students, they don't really know what the human's made of. It's fascinating. Or you'll get you mean carbon-wise? Carbon, nitrogen? No, I mean tissue-wise. So, and this is the, otherwise lean human, which has 10 kilos of fat on it. That would be skewed in my clinic to the human body being mostly yellow, mostly fat in an obesity medicine clinic. And so I'll reason through, why aren't you using the fat? And it's because you're eating carbs. And I'll draw that out depending on the individual's interest and all. So I think it's important to separate out what we're made of and how to fuel the body. They're really two separate issues. So eat protein and fat to replace the body composition, and eat carbs or fat as fuel. It's your choice. And in the book, End Your Carb Confusion, we really have that whole 3-tier carbohydrate levels, which is a theme throughout low-carb diets. There's the keto level, there's the low glycemic level, and then there's even a level if you're an athlete. So when I talk to athletic trainers using this approach, they'll say, I have clients who eat 100 grams of carbs a day and they're still in ketosis because they're active and exercising so much. So the method I learned was from Dr. Atkins, remember? I went to an office that had worked out a plan over 30 years, and it was really kind of unexpected of me and my colleagues back home that he would let me study it. So basically he gave away his intellectual property for nothing, and wanted to have the research behind it. So today when I teach a low-carb keto diet, I have one sheet of paper. What I might do is, Penny or Claire, if I could send you the sheet of paper or the color one. It's same as phase 1 in End Your Carb Confusion, the book. But if you're a practitioner and want to use it, literally, I'll just hand out that sheet of paper with some window dressing around it. That video is available online, the white coat video. And so I've taught doctors through the years to just hand out the piece of paper and direct the patients to watch the video. Right now I have a QR code on the wall that so people just look up there and find the YouTube video teaching class, go over it at home. So I don't really spend any time teaching this in the office, which I learned that through the COVID era where we were unable to meet. I used to make people come back for a video for a class in person, and and people would be falling asleep, and because their sleep apnea was so bad, or they would say, no fruit, no fruit, like this, the reaction to changing the food. So you can expect that it's kind of a shock, but the real interesting thing on this sheet of paper is that you start with protein. And so when you're hungry, you eat as much as you want of these proteins. Protein will carry the fat with it. And it doesn't really matter if it's plant-based or animal-based. The approach I've learned is animal or omnivorian. But you eat as much as you want of meat, poultry, fish, and shellfish, and eggs. And if you lived on Hawaii or South Korea, you'd be eating a lot of spam. Interestingly, there was just a few, that canned meat thing. I don't know do you get it in Australia and stuff? Yeah. So it can be really low in carb. I was at a meeting. I was talking to another doctor from around the world, or he lived in Hawaii. I said, I hear there's some spam in Hawaii. Within an hour, he had his wife take a picture of all the different types of spam on the grocery store shelf. So that's fine with me as a protein source. So this kind of cuts across a lot of the expectation of super clean eating, of expensive foods. It doesn't have to be organic, so you can have as much as you want, meaning till you're comfortably full. And of all the dietary approaches, this is the really only one that, well, okay, if it's a very filling kind of fiber-based diet, it becomes low calorie because you can't eat much. Because I remember saying this is the only one where you don't have to count calories, and a vegan guy got up and said, well, in our studies we didn't count calories, and so or make people do that. So there are many ways to not have to count calories, I guess, but in this way, what happens is your body starts burning fat, and that gets you to start eating less. So I don't tell people to limit the amount they eat. It really happens automatically. So eggs, I think, are the perfect food, which often, but I thought eggs were bad for you. No. So someone says, well, eggs raise the cholesterol. I say, well, which cholesterol? Yeah, it raises the good one, raises the HDL. So I just want to throw a little barb in there because I know they're going to go to the other doctors or dietitians and say, you can't eat all of that. But remember, my first two patients had improvements in their cholesterol levels, which looking back, the odds were actually in my favor, but they're not 100%. So it was possible, if the universe said they would give me two patients whose cholesterol got worse in 1998, I wouldn't have continued to research this. So that, just tell people, don't worry about, we'll talk about that later. Don't worry. So you want to just overcome some of these barriers, and you don't avoid fat in real foods. You don't add fat if you're trying to lose fat weight. Now we call it internet keto, where there are super users who teach other people, influencers, and steak and butter gal is out there basically, pounding half a stick of butter, but she's lean, so she can do that. But if you don't want to push fat, so we call that internet keto because it kind of came out when all of these bells and whistles started getting, or ornaments were put on the Christmas tree of low carb research. There's never really been a study of using medium chain triglyceride oil in a program like this, or using apple cider vinegar or coconut oil or butter and coffee, and all these things were kind of just glommed on at the same time. And the basis really of any diet should be protein. When I look at a follow-up visit form, I do ask people to write down what they're eating when they come back. I don't make them do that at home. I just want to make sure they're eating something from this panel, from the protein list. And because really, as time goes on, there's a lot of controversy now of how much protein you really need. The whole idea of autophagy, that your body is recycling itself is new. And it really hasn't hit the world of obesity treatment and even of bodybuilders. So protein comes first. I do allow for, and the way I learned this was to allow for 2 fistfuls of leafy greens. And I say, throw away your measuring cup, compare it to your fist, and you'll find it's just about the same. So you can estimate the volume of the greens. You don't have to be measuring this. And that some people will look at this and say, oh, no, I have to have it uncooked. No, it can be cooked. It's interesting how people will interpret things. It says measured uncooked. But that's part of the battle we have, is most people don't get teaching on what a carb is, or how to prepare foods. And the brilliance of this list is you don't have to know any of that. You don't have to teach macros. You just say, follow that list. Most people will know what a artichoke is. Or if they don't, they just won't eat it. So I say, choose what you like from this list. And it finally occurred to me after watching Sally Norton, who's an internet influencer, PhD, has a book on oxalates and oxalate dumping, and it's just the terrible. I've never seen it, and now it occurs to me. I ask people to eat a little bit of oxalates, which prevents the dumping. Now, Dr. Atkins died 3 years after I met him, so Jackie Eberstein, the nurse that worked with Dr. Atkins, is still around, but they never really considered oxalates as a problem. And I think it's because they never saw it with this system where people had a little bit of veg, a little bit of oxalates, so you don't get this dumping. So the story of Sally Norton is she, cried alarm because everyone was doing this carnivore. So there are people doing carnivore diets getting oxalate dumping, and it's because they're not eating any oxalates at all. So this becomes a very low oxalate diet, and because there's no grains, this is a gluten-free diet. Because there's no simple sugars, this is what's called a FODMAP diet as well. So it's like the granddaddy of elimination diets. And remember, I just went and got it from someone who had already kind of worked it out, and then learned that, well, actually they're doing a subset of what this is, and you are getting a little bit of oxalates, to maybe that prevents the dumping. Now, I have to say, I have one patient who came in to me with these little crystalline things that came out of her eye, and she put it in an envelope, and I said, well, I'll see what I can do, see if I can get it. Nobody will analyze it for me. So if you're a chemist by background and know how to figure out if something is made of oxalates, let me know. So I think it's a thing, but I don't see it in my practice, maybe because people are getting a little bit of oxalates. So you can have in this system cheese up to 4 ounces a day. You don't have to have a scale to measure it. You just eyeball. A string cheese is 1 ounce, a slab of cheddar, 8 ounces. And the main thing here is that these things are limited. And I think that's the secret sauce of this method that people are trying to re-engineer. And, if an influencer says you can have all the cheese you want, and they're trying to get people to lose weight, no. So this came out of an obesity treatment practice. They knew with trial and error they had to limit the cheese, creams and oils, and mayonnaise because these are such high calorie items. So really the list that I borrowed and then studied is a blending of low carb keto and a low calorie approach without really saying it. And then those items down at the bottom. And I say, eat what you like. I spend no time on food preference, much to the consternation of my friends who are dietitians who spend all this time trying to find what people like and creating menus. I say, eat what you like off the list. Pretty simple. Zero carb snacks means if there are no carbs, it means it doesn't raise the blood glucose much. It doesn't raise the insulin much. There's a quantum difference between carb-related insulin rise and protein-related insulin rise. It's hardly anything. And you need a little bit of insulin to get the proteins in the cells in that anabolic effect. So the strange bedfellows in this list is sugar-free Jello, which is like a gelatin diet Jello, zero carbs, and pork rinds. Pork rinds, chicharrones, or pork skins, meat skins. It's in our area kind of a Hispanic or Latino based kind of food. Pepperoni slices, low carb jerky, boiled eggs. I'm trying to think, I don't remember his name, but there's a gentleman who's trying to get research done in the middle of Australia. He said that they're eating what animals now are all over the place?
I'm going to guess kangaroo. No, is that
No,
sheep?
no, it's like someone else say
Wallaby?
could be giraffes.
No.
This is like in
Oh,
the
camels.
central
Camels. It's camels.
camel.
Okay.
That's
Oh, wow.
this tall thing. So some Aboriginal groups are resorting to eat camel. I think that would be fine. Not what I know about the food. No, it has to be fresh, relatively, or cooked or something. That reminds me of the movie The Magic Pill. If you've never seen the documentary film, they start with one of the oldest groups they think they know on Earth, which was an Aboriginal group in Australia. They all developed diabetes, and by the end of the film, they don't have diabetes anymore because they cut the carbs out for that group. They also follow a young girl who has bad autism or on the spectrum that gets helped by the diet. Anyway, the magic pill meaning the diet. There is no magic pill, but that's a wonderful film if you'd like to learn or teach by documentaries. Yeah, camels. Sorry, not giraffes. I've been to Australia once, so and I do watch, things like reality shows that take me there. But yeah, I have lived a sheltered life. So let me toggle back to the science. So that's the simple method, really. It's one sheet of food, one piece of paper. The science, of course, this is the public health collaboration of the UK. I was invited to speak there this summer. This great group, Dr. David Unwin and his wife Jen, are kind of the UK proponents or leads for low-carb diets. Sam Feltham, of course, works for the public health collaboration, and they basically put out years ago that if the score is low carb, it has more weight loss than low fat. It's basically a no-brainer. Low carb diets win, and now low carb diets through years have been put into recommendations by organizations, but it's been tough because most doctors really don't get nutrition training, and for years it was the impression of the doctors here at Duke who used the clinical diets. There was actually a low-fat diet called the rice diet, and it was our impression that they both worked, but we didn't wrestle with, well, how could that be low fat and this be high fat? The metabolic effects were the same. That's what we would see. So finally, we talked about we should do a head-to-head trial of Atkins versus Ornish, and finally, Lucia Aronica did a sub-study within a Stanford randomized trial with Christopher Gardner, the PI. And the metabolic effects of the ultra-low fat and ultra-low carb diets look the same. In fact, low carb won out a little bit, but I'm not going to lord that over, because everyone assumes we're not, or the low carb isn't good. So to say that it's better, no one will believe you. But so organizations are going to come around, but it's happening slowly. For diabetes, 100 years ago, the low-carb diet is all doctors had. In fact, one of my patients here, this is a textbook of medicine by Sir William Osler, the father of internal medicine, 1923. And one of my patients looked and he said, 15 grams of alcohol. I can have alcohol. Yeah, you can. And even on a low carb diet for obesity and diabetes treatment. So I'll use this as a show and tell in the office. The piece of paper, the book is too tattered. And I'll say, look, 100 years ago, they used the same thing I'm teaching you now to reverse diabetes. But now what's so obvious about this is that if you poured out all of the blood of a human, let's say 5 liters for an adult, and measured how much sugar was in the bloodstream, it turns out that it's a teaspoon of sugar. That's it. So 5 grams of sugar is about a teaspoon. And so if you eat more than a teaspoon of carbs, sugar, and I gloss over the detail that, okay, fruit is, sucrose is half fructose and half, you really don't need to get to that level of detail. People know if they eat an apple, their glucose monitor goes up. That's revolutionized the care and even the introduction of this to pre-diabetes and someone who has diabetes, because they see the response to the glucose on the first day that they do a low carb diet. But so I'll explain that, there's only a teaspoon in the blood, and an apple has, 4 teaspoons. It's no wonder that the blood sugar will go up. Now, David Unwin and the Public Health Collaboration of the UK have formalized the teaspoon idea into handouts that are great for patient education if you need that. I find that's too much. My patients don't want to know that detail. Kind of like going to the mechanic to get the car fixed. They just want it fixed. But maybe your patients want to know that detail. The science about diabetes reversal is solid. The Virta study and then the Virta company has done really well in the US to teach people with an app, talking to a doctor to take people off the medication with a Bluetooth scale, and they use a ketone and glucose monitor with these ketone and then a CGM. So it's kind of high-tech diabetes reversal. We can do the same thing being low-tech, but I love using a continuous glucose monitor if possible, just because people don't have to prick their fingers to see their blood glucose. But this is a must-read if you're working with someone who gives you pushback about this in the use of for people with diabetes. Now, for cholesterol, which is still kind of a sticking point, I use this paper by Jeff Volek. That just basically shows a low-carb diet works in a different way. It addresses the triglyceride and HDL, not the triglyceride, not the total and LDL. But you get a lot of people who think the only way to treat something is total and LDL with a drug. So no, it just treats the metabolic syndrome for cardiometabolic risk reduction. And then the idea of metabolic syndrome or insulin resistance is not new. It goes back to Dr. Gerald Reaven, who was at Stanford in the US, and it really just became a marginalized alternative hypothesis, but it's always been there. And yes, you can criticize and say, but you've never done a randomized trial looking at metabolic syndrome and death and dying and outcomes, and that's true, because there hasn't been the wherewithal, the funding to do that kind of study yet. So I'm hopeful. I took a couple meetings in Europe this summer, the Keto conference in London, Public Health Collaboration, and then Keto Live in Switzerland. And the new science coming out is just really, really supportive of this. Even young women in their 30s who choose to do keto, the blood looks great, the people feel great. Even a couple of them had babies without eating carbs, God forbid. So I've been kind of rejuvenated in sort of a, when is this finally going to take off? And I think it's happening. 20 years since our first paper, but the groundswell is also evidenced in the change of the food supply. So we have keto bread, which I don't recommend to my patients, but at least it's out there. We have keto ice cream, which I don't recommend to my patients, but it's out there. So it's lower in carbs It's not really right for a keto level, but there's so many people who don't need keto. They just need a reduction in the carbs. I think it's great that its food supply is going in that direction. So just as a reminder, not all low-carb diets are ketogenic or keto, develop ketones in the blood. This is different than just drinking ketones or infusing ketones. Those studies are being done, but the metabolic changes are much more in depth than that. So you can use a low-carb diet and get a lot of benefit from it. I think that's kind of the question that will remain if you find something that a keto that works. Like there's an initiative now looking at mental health problems. It may be that you can get that kind of benefit without having the ketones and ketosis, but we just don't know yet. So a lot of grassroots change that's led to now studies being done. My clinic that we opened some years ago has a clinical use, but it's been difficult to put it into papers. Just this last month, the Journal of Cardiac Failure, Journal of Cardiac Failure 2025, one of our medical students did as a project a summary of the patients who had heart failure who came through our clinic. There were 125 people treated, and on average, the ejection fraction by echocardiogram didn't change over a 1-year period. And the weight loss, of course, was better if they were super adherent. You're going to hear more about ketones and heart failure because one of the drugs that doctors, cardiologists especially, use causes ketosis. And that seems to be the mechanism for the reduction in heart failure events. These are the SGLT2 inhibitors, Jardiance, Invokana, are the brand names. And I'm cautious with using those in someone on a keto diet because they can raise ketones by themselves, even if someone isn't on a keto diet. So what's going to be really interesting to see is how a cardiologist who generally teaches low-fat diets finds out that ketones can be beneficial, and how are they going to put in their head that you can accomplish ketones by eating fat? This is going to be a barrier, I'm afraid, and I don't want you to worry about that because you can get ketones internally by not eating carbs. And yeah, that means you might eat some more fat, but not necessarily if it's a protein-based diet. So these clinical papers are done, and I think what I wanted to end on is that carbohydrate is not an essential nutrient. You don't have to eat carbohydrate. Your body's fuel comes from what you consume. The human body is incredibly efficient. If you consume mostly sugar and starch, you will use sugar and starch for energy, for fuel. If you consume mostly fat and protein, you will use fat and some protein for energy, for fuel. If you consume mainly carbohydrates, fat burning and ketones are inhibited or blocked. And that's my explanation to my patient when I'll even pull up the pantry and say, look, your fat's in here, why aren't you using it? It's because you're eating the carbs, the insulin goes up, and that locks up the fat store. And yeah, I make kind of a dramatic movement in the clinic so people will remember that crazy doctor was talking about fat in the pantry. Physiologically, an increase in insulin favors lipogenesis, the creation of fat, blocks lipolysis, and leads to obesity and type 2 diabetes. Blocking ketosis causes seizures in children with GLUT1 deficiency and actually helps a lot of children, even if they don't have the GLUT1 deficiency. Now the mental health field with the Bazooki Foundation and Metabolic Mind is the presence online, is learning that like a seizure disorder is a brain disorder, mental illness is a brain disorder. And this approach is already effective for some people, the anecdotes, case series, but those studies are being formulated now to see just how wide that impact might be in the mental health world. The orphan diseases like McArdle, which is a glycogen storage disease, the paradigm was to feed people carbohydrate all day long because they can't use fat. Because they can't store glucose. They could use fat all along, it was just suppressed by the paradigm, and the people themselves from McCardle found that this is helpful, and they actually have started to influence the world researchers on that orphan disease. So in the perspective now, there's a lot of science and a lot of evidence historically, observationally. I didn't put much emphasis on that, until now, kind of tying it all together. And also with Jeff Volek saying, there's never been a study that showed a low-carb diet's bad. And so I'll use that in the right research context. Still, there's the bias, the discrimination, the prejudging of the diet being bad. We face that today. Cholesterol being the main kind of tension point, that the old way looks at total and LDL and uses drugs. The new way, this way, looks at triglyceride and HDL and uses diet, uses lifestyle. So, this was my final slide, sorry. The clinical research is substantial. Finney says, and Finney is one of my teachers, Steve Finney, that the study, there are more studies on low-carb diets than any other diet. And that's because people thought it was bad. They all wanted a chance to knock it down. And it's an accepted practice now, I'm confident to say, used for obesity and type 2 diabetes with endorsement by several professional societies. But the context must be considered when comparing labs, and that's why when I bring up the cholesterol comparison, the difference is not necessarily abnormal. And when you look at a normal range of labs, you're looking at people who are eating carbs. More research is needed to look at the basic understanding of fuel for cells throughout the body. And I think the question should not just be, can the cell or does the cell use glucose, ketones, or fatty acids, but rather the question should be, what fuel is optimal for that particular cell? And I think we're finding through a lot of great grassroots observational information that this approach is going to surprise a lot of people, thinking that it was bad and now it's good. But think of the physiology, the biochemistry, what the body is made of, protein and fat and water, don't forget water, and then you can fuel the body on carbs or fat. It's really your choice, unless you're an addict to the sugar. That's a whole nother discussion. Thank you for your attention, and I wanted to be sure to spend lots of time for a Q&A.
Fantastic. Thank you so much, Dr. Westman. Ron's giving you a clap there. Practical, and I feel proud because, I already tell patients, keep your cheese at 100 grams a day. I'll show them a camembert wheel of cheese and say you can have half of that. Because I started with you, I never get caught out by those little tricks like people drinking coffee with cream and wondering why they're not losing weight, because you've solved all the problems already.
Well, it was Dr. Atkins and that team. Yeah.
Yeah.
They used it for 30 years.
Yeah.
Of course, the environment's different, and so you have to watch high calorie items still on a low carb diet. Yeah.
Yeah. Thank you so much for your time. Fantastic questions, everybody. Learnt so much from you. Thank you, Dr. Westman. We're so grateful. Enjoy your evening.
Hope to see you soon.
Yes. Thank you.